talking about having made a profit last year and, to quote, making an even better profit next year. What's this about? I thought that Locala existed to deliver services to people, not to save money.
So we do exist to deliver the services. However, because we're not part of the NHS, we do need to live within the means that we have, otherwise we will cease to exist as an organisation. So as part of our financial planning and making certain that we are viable as an organisation, we need to make certain that we are able to operate within those funds and to give ourselves the headroom to do so. From the aspect then of existing as a social enterprise organisation, we invest back into the local community already in return in respect of supporting voluntary and third sector organisations, and we are looking at how we invest some of the surpluses we've made previously back into the locality to further support that, whilst continuing to make certain that on a year-by-year basis we are actually viable and can deliver the services we need to do so to the relevant quality, but within the finance that's available. And that's a slightly different situation from the NHS organisations, where if they do run a deficit position, they will get some support. If we run a deficit position, we will go out of business.
Nell, do you have a supplementary question?
So is a surplus of 1.6 million what you describe as living within your means?
So a surplus of 1.6 million isn't what we're planning to make or what we made. We made a surplus of just over £300,000 last year. We're planning for a surplus of £600,000 for this year. 1.6 million is the level of savings that we need to make in order to be able to achieve that.
Are you okay with that?
Well, I won't ask any more questions.
Okay. Peter, would you like to ask?
Thank you. Just on, while we're on with the whole business of partnership, working and jointly funding things, and to come specifically to care closer to home, I just wonder how that is being funded, because it seems to be fairly significant as we move forward, as we reduce the bed base. So I just wondered how that worked, because we get a lot of anecdotal evidence that if you're cared for in the community, nobody's actually in charge of your care plan. And yes, lots of very, very helpful people, the GP, the carers whom Kirklees hire, lots of people go in, but nobody actually pulls it all together. I really wondered how we were dealing with that from a financial point of view, please.
Okay. So we get one budget. So whether we fund acute services, hospital services out of that budget, or community services, it comes out of the one allocation. I think as part of the Right Care programme of work, Care Closer to Home, the CCG have given a real commitment around improving our community services and investing in those community services. The allocation increases for next year. Primary care gets a bigger increase in funding in a year we're coming into now than acute services is getting. For our community services, on top of the sort of various nationally directed funding, locally we've put aside now £1 million of our allocation specifically to improve our out-of-hospital services in Greater Huddersfield, and we put aside 800k in North Kirklees, even though that's in a really challenging position. So across all of North Kirklees there's £1.8 million set aside of, in effect, funding we didn't have to set aside to meet any national requirements. So I think it's the first year we put funding like that aside. Obviously the proof will be in coming forward with the schemes that are going to make a real difference to our population and improve the services that we get. But certainly within the financial plan, I think more so than we've done in previous years, we've set that funding aside for out-of-hospital care and a big investment in primary, sort of GP and primary care services.
Thank you. And just if you could clarify, please, something that Martin touched on. What percentage of the actual budget is dedicated to servicing the PFI debt, and is that non-negotiable?
So our funding goes to the trust. So we fund hospital services. It's then for the trust as a provider to then decide how they spend that. So for both of our providers, there's an element of their cost which is PFI. But we don't commission the PFI separately. We commission the total costs of the trust. And so I must admit, I wouldn't know what their percentage is on PFI, but it's their discretion to spend it between buildings, staff, and all the rest of it.
But there's a percentage of budget for Mid Yorks and Calderdale and Huddersfield. How much is it swallowing?
Yeah, how much in total do they get of the total allocation?
No.
How much is PFI?
Yes.
PFI. Yeah, I don't know. I don't know if you both know that.
That's a test of my memory, and if I am wrong, I will email you. But roughly speaking, I think it is about 6% of our budget is the sort of annual payments to the PFI provider.
And that's totally non-negotiable?
Yes, it is. I mean, so the payments consist of a number of elements to it. One is the sort of costs of the equivalent in layman's terms of the mortgage payments. We also pay a annual sum that covers the maintenance of the physical infrastructure. In addition to that, we pay each year for what's called soft FM, which, for example, is portering services, cleaning services, laundry, catering, etc. And we are bringing all of that in-house from November. But in relation to the other components of our annual pay, it is non-negotiable. It is a legally binding contract when the sort of PFI deal was done. We have looked at whether their economics of buying the PFI out, but the nature of the original PFI agreement and its funding sources, there is no way of doing it that would be cost effective.
Thank you. And Calderdale.
Yes, so I've just got my phone out of my bag to check the percentage, and my calculator tells me that it's a very similar level to the Mid Yorks in terms of the percentage of our overall budget is approximately 6% that we spend on the PFI services. But similarly, that's not about the mortgage payment as such in itself. That covers that type of payment, but also again the soft facilities management services and the maintenance of the estate and so on. Again, it's contractually committed, and that is something that we are bound to, those contractual commitments. We did have some success last year in an element of renegotiation on the soft facilities management services, and we were able to secure some reduction in that contract. Aside from that, it's within the bounds of the contract going forward.
Thank you for that, Peter. I'd like to ask a question in terms of your budget. How do you prioritise where your services are located? Because the perception in the community is like Dewsbury is a declining hospital and everything seems to be going to Pinderfields and Pontefract. Could you explain that to us, please?
Before my time, the Trust agreed an acute hospital reconfiguration of services, and that was agreed with both North Kirklees CCG and Wakefield CCG, and I'm probably telling you things you already know better than I do. It was the subject of absolutely extensive consultation, public consultation, and so on. And so that was how it was determined, and in the main, the thing that has changed is the use of inpatient beds at Dewsbury Hospital. There's been no change to outpatient services at Dewsbury Hospital. There's been no change at all for radiology services, and there's only been a minor change with regard to A&E services. And the minor change for A&E services is about 30 ambulances a day that used to go to Dewsbury A&E now go to Pinderfields. But the actual number of people attending the A&E at Dewsbury Hospital has gone up, in fact, since the acute hospital reconfiguration was completed in September 2018. So the number of people using the A&E department has gone up slightly. The number of people using outpatients and X-ray and CT scanning has marginally gone up as well. So there's, I can't remember the exact figures, but there's something like 400,000 people a year still use Dewsbury Hospital from the North Kirklees Clinical Commissioning Group population. So it still is a really, really busy hospital providing absolutely relevant local services. The only thing that has really changed is that when somebody is acutely ill, they will go to Pinderfields Hospital, where most of the medical staff are based, and emergency operating theatres and everything else, and intensive care and coronary care is based, but everything else has stayed the same or growing. What we are looking at is how to transfer more planned surgery out of Pinderfields Hospital into both Dewsbury and Pontefract. So your counterparts in Wakefield would also say we are not using Pontefract Hospital enough, and that is a moot point. But nevertheless, we are keen to do more planned surgery in both hospitals. And coincidentally, only last week, I visited, I spent a couple of hours in the operating theatre department at Dewsbury Hospital to get a more personal, detailed understanding of the services provided, what are the constraints that we need to overcome to make more use of it. Does that answer the question?
Yes, you have answered the question.
And just one other bit for me as well about how the funding works. So we will fund wherever our patients go. So if patients goes to Pinderfields, we fund that. If patients goes to Leeds, equally if a Leeds patient comes into CHFT, then the funding will come from them. So it's not just our, we will fund services where our patients go and best get that care, wherever that may be.
Is that through patient choice that you're talking about in terms of
well, certainly
allocating?
yes, so absolutely. So patients on elective referrals, patients at their GP surgery, patients will then get the available choice on where on where they go to. I mean, lots of things will then influence that choice, but yeah, there's patient choice in that.
Thank you for that, Fazila.
Hi. So you talk about about deficits, making savings, making sure you're sustainable to carry on in the future. The cuts that have been made, what kind of audit process have gone through to make sure that the cuts to services doesn't impact those ordinary people that you are obviously providing those services and we're not in a wheel, basically, that they come back into services because they've not, because we've cut the services off to make those savings, but later on in life, we've not been able to provide that kind of care for them, so again, we need to have to invest in them. So what kind of an audit process has been made towards the savings that you've said you've made? You've made so many savings for free services. What's been done for it? I know it's a general question, but I am looking for a general answer, and I don't want to know about everything.
I think we probably all follow variations on a similar process, but from a commissioner perspective, where there is significant service change, then there's all sorts of rules laid down about the public consultation that we need to do and be really transparent about that, and come into scrutiny committee and all of those. So we have public engagement and public consultation processes for significant service change. Any service change that we do as well will be subject to equality impact assessments and quality impact assessments when we're commissioning a service change. I think providers will do a similar thing, but I'll let them answer for that.
One of the main reasons why we've not achieved our control circle is because we haven't actually cut any services, and the number of people that we employ has grown by more than 400 people over the 3 years since I've been there. And but when we do make efficiency changes or productivity changes, they are subject to what's called a quality impact assessment. Inside the trust, these are signed off by our Director of Nursing and Medical Director, and in turn those quality impact assessments are shared with the relevant clinical commissioning group. So there is a system of checks and balances to provide some assurance that harm is not coming to patients.
Thank you, Chair. I just wondered, Ian, and I think I might have asked you this before, so forgive me if I'm being repetitious. It's something that affects us coffin dodgers. I just wondered what powers you've got for environment within your budget.
Yeah, so they're set down in statute. So the NHS Act says what we can spend our money on. So there are, we can't just go and choose to spend our money on something that's not directly to do with health services. We'll be ultra-vires if we did that, and that's not. So that defines what we can spend it on. On our total allocation, we've got a large ability to move money, but certainly between acute and community and all of that. We get a separate allocation for primary care allocation that was delegated to us from NHS England. So we have to commission our GP and other primary care services out of that allocation and do that in conjunction with NHS England. I don't think we can spend less than that on primary care, but we could certainly add to it if we wanted to. So I think there's some constraints around if we wanted to spend less on primary care than what's in our allocation. But outside of that, we can move money around, between the different parts of our health service. I mean, obviously, we've got contracts with providers, so we can't, but within our total allocation going forwards, we can decide to spend more on one area, less on the other. But it's about the ability of services to change that quickly and working with our providers where we've got contracts.
Thank you. And what's your criteria in assessing whether you're getting value for money?
Yeah. So we have a responsibility. So part of the audit of our annual accounts is so the independent external auditors do a test around are we achieving value for money. Any business cases that we get through, we have to demonstrate within that business case its value. And it is quite difficult in the end. It's not just an automatic calc. Some things are really grey. This improves services. It is better for the patient. So we look at our outcomes. So on our business cases, we'll look at what outcomes we're going to. How many patients are we going to treat? What outcomes are we going to achieve? Is it cheaper than doing it in a different way? If it is not cheaper than doing it in a different way, are we getting just demonstrable better outcomes for the extra investment that we're putting in? So we ask all of those sort of questions when we look at business cases. And in our contracts, We'll meet monthly with each of our providers, and there's various sort of key performance indicators, quality indicators, as well as sort of volume of activity indicators that we hold our providers to account for as well, to make sure that we get, that we get good value for each contract.
Just one last one, please. Have you, in these figures here, and I suppose this applies to all of you, have you factored in what new monies will come from Mr Hammond's 20 billion promise?
Oh, for the well, we have got a so these figures are all 1920 figures. So we've got our allocation. We know what they are. So there's nothing factored in for the this is about 1920. We've got our allocation for the next 2 years. So we've been notified of that. So as part of our longer term plan, we've already got those figures.
Thank you. Nell?
Yes. Ian, do you have any scope for saying to Locala that you want a cap on their profit or surplus, or are we just bound to wait until the contract is up for renewal?
So we have a set. I'll let Richard come in as well in a minute on this. We have a set contract with Locala. We have a service specification with Locala detailing what services need to be provided. There are lots of key performance indicators within that, which holds them to account around quality and what's provided. We don't have a separate indicator that says profit. They're not a private company. They don't have shareholders. So I think there is a question around where does a surplus go, and Richard can, I think, he's explained that a bit already. But we don't have a separate indicator around that.
But 0.6 of a million is probably enough for 3 more chief execs, isn't it?
We equally use the independent sector, and we don't have an indicator around that about what profit they should make. We don't have an indicator around it with each of our trusts, whether they're in surplus or deficit. With our GP practices, we don't have an indicator around that, so we don't have that indicator with anybody that we commission from. We have an indicator around what services we need to get provided.
Alison?
I've got a question, but it's in connection with Kirklees Adult Social Care. Is that okay to ask it? Okay, this is a question for Kirklees Adult Social Care. Hello. It's in relation to, with regard to demand-led client provision, independent sector home care was underspent due to a lack of capacity in the market to meet assessed use and needs, and I just and that was set off against the alternate spend on residential placements. So my first question is, are there any plans underway to change this? Because obviously this is not a good position to be in. And if you could explain the outcomes for spending as well, please. Thank you.
Okay, so I think this represents a national picture where we have a struggling provider market for independent sector home care. It is our absolute intention to keep people at home rather than move people into placement settings, and so we are working with the independent sector home care market. We've run a series of innovation labs recently, working in collaboration with the providers and with strong partnerships around how we can seek some solutions to these issues. Some of that is around focusing more on outcomes and away from time and task-based activity, and strengthening that relationship. It is a difficult situation, so it does see us having to use short-term beds specifically to facilitate discharges from hospital where we can't set up home care quickly enough. So that is a regrettable situation, but we are working our way through it.
Thank you. So I'd just like to ask a supplementary question in relation to that, which is, do you have a time frame for this? Because obviously this can't continue in forever. I just wonder if you're working to a time frame or a time schedule.
We're working to a time schedule in terms of we're starting some pilots, so the outcome of the innovation labs that we agreed that we would test some new ways of working, so those will be tested over the winter period and then we'll be evaluating the impact of that. But I think there is a correlation there as well with the sustainable funding that we need to have in order to be able to address the recruitment, because temporary funding always has an impact on a workforce that you cannot switch on and switch off over a winter period.
Okay, thank you. And my next question again is it's in connection with the last paragraph of the report from yourselves, and you state there it's achieving a balanced budget is becoming harder and harder each year. So it's probably fits in with the last question, but it's a question around sustainability in the future. Is it unsustainable at the moment? And again, do you have some plans in place to address this sustainability issue for the future? Thank you.
Yeah. So in terms of sustainability, the balanced budget this year was based on the use of the short-term funding that's set out in the table. So we've made full use of that. Some of that money has been used to help us to transform. So we've released some staff for transformation activity, and so that is short-term commitments which will deliver efficiencies going forwards. But some of it is being utilised, for example, to help us through winter when we see the demand for placements going up. So we do really need to have a sustainable footing. It is quite difficult, and the growth is there in terms of demand. So there's a lot of our transformation activity is looking at how we can improve outcomes and manage demand in a timely and responsive way whilst delivering efficiencies.
Okay, thank you. Peter, would you like to comment?
Thank you. I just wondered, while we're thinking about care in the community, I just wondered if as a collectively, if you thought that primary care networks were a cause for celebration or a cause for gross concern. Just wondered how you were, how you were approaching it.
So I firmly believe that they are a cause for celebration. I think the situation that you described earlier around people receiving uncoordinated care from a range of different agencies will be resolved as we start to work more closely around place-based areas, so that we can collaborate much more around how we manage people's conditions, and we start to look at the whole person rather than lots of different factors that impact on a person, and also looking in the context of how we connect better as communities to support people with the underlying causes of poor health, really.
Thanks, and probably one for you, Ian. Have you received any seed funding for?
Yeah, so primary care received a bigger allocation than other parts of the NHS for this year for that reason. There's a new GP contract that's very specific about how we should fund GPs and being part of a primary care network. So a part of our overall allocation, we've got a bigger growth for our primary care to spend on primary care networks to get them started. And there's things like the national announcement about social prescribing and all sorts of things like that. So there's a fair amount of the total pot. There is a fair amount going into primary care to make this a success.
And just one last one, please. Funding for public health. The learned journals are redolent on comments about the way in which public health is being starved.
Yeah, so public health is provided by the local authority now, and that comes out of their funding, so I'll let them respond.
Sorry, the question was about allocation of funds specifically for public health.
No, it's fine. That's fine. So for those of you who don't know me, I'm Emily Parry-Harries. I'm Head of Public Health for Kirklees Council, and I'm here for the next item, but if it's all right with you, for me to answer the question. I thought your question about whether to be excited or nervous of the primary care networks was an interesting one. I'm really excited by them, and while it's not about the money, it's about the relationship that we can build and have in a much more effective and efficient fashion. And public health can influence that. So we're working to develop data packs for each of the primary care networks so that they understand their place better and can respond to those health inequalities. There are some specific elements mentioned in the long-term plan for the NHS that are what we would have traditionally considered to be public health. So there are some specific things referenced like smoking cessation, opportunities, weight management, that we in public health are really pleased to see there, because it strengthens the NHS's commitment to those kind of fairly medical model bits of public health. But the real gains for us to be made in public health are getting things like the wider factors and the places where people live their lives right. Is that all right?
Thank you for that. Is there any further comments on this item? Okay, in that case, can we... sorry.
One last question. The final sentence from the Locala report: discussions have been had with the Council about a joint programme to target funds into the community. Who, with, and where do we stand with it at the moment?
So the discussions have been had by Karen Jackson, who's our CEO. I'm afraid I don't know who particularly in the council that is with. I believe it might be with either the chief executive or head of adult social care.
We've started to have discussions around could we explore some of our grant making. Would that be better combined in terms of being able to attract more money, but also with other partners as well? So we're hoping to talk to One Community, for instance, as well, but that may be a different issue to that. But we've certainly started to talk about our grant make. We both have grants schemes. Could there be more economy of scale, more outcomes for communities if those were synced together, if they were joined up? Because often money can attract more money if you have substantial money with trusts and also grant making bodies. But very early discussions from the perspective that I'm aware of.
So the funds you're looking at are not the surplus that Locala currently hold?
So the amounts that we're looking to invest are from the surpluses that we previously made, yes.
Okay, if we're okay with that, if we can move on to the recommendation of the report. If we can accept the report and take into account the information that's been presented to us. In addition, I've got looking at the sustainability of all the areas we've talked about today, and maybe looking in detail when individual items come to one of the future meetings. In particular, the care closer to home, look at the care plans with named employees taking sort of responsibility. I mean, you don't need to name them to us, but, you know, in terms of accepting more responsibility, in terms of some of the things that were mentioned earlier on in the meeting. And with each organisation that's named in the budget plan, if they can come back to a future meeting with, you know, sort of clearer outcomes of what they've achieved rather than waiting until the next financial year. Is that okay? Thank you for your attendance to that. We'll take a couple of minutes out for the officers to leave. Can we move on to agenda item number 5, which is setting the work programme for 2019 and 2020. Would you like to introduce yourselves and present the item to us, please?
Jill Greenfield, Head of Local Integrated Partnerships with responsibility for the wellness, Integrated Wellness Service.
Good morning, Helen Severn, Service Director for Integrated Commissioning for the Local Authority, the Council and the 2 Kirklees CCGs.
And I'm really here now. Emily Parry-Harris, I'm a consultant in public health. I'm Head of Public Health for Kirklees Council.
Well, the purpose of this report is to consider the areas of inclusion in the panel's work programme for 2019 and 2020. If we can go through each section of the report, of the work programme, and maybe we can have a discussion on that and take comments from panel members. Is that okay? Okay, so would you like to start on the first item?
So the first item was the financial position, which I believe you've just had an update on and have made recommendations and asked for further dates when you want it to come back. Sorry. Can you hear me now? If I'm too loud, tell me. So the first item, you've just had the update on the financial position, and you will call that back when you feel necessary to review the item. So the second part around care closer to home, there's been some comments from adult social care, wider partners within the council, Community Plus and the colleagues from the CCGs around how we might approach a discussion around care closer to home and ensuring that we're engaging with scrutiny in about the whole pathway from promotion and prevention of individuals building on their strengths base, living within their communities, building community capacity, and hopefully further down the line preventing the need for more complex care and intervention and attendance and admissions at hospital. And in line with the health and wellbeing plan outcomes and priorities, we thought it would be useful to gather it as like a workshop style event, if committee would welcome that, to be able to go through in some further detail the principles we're working to and what we're trying to achieve with that whole programme, and including there the developments around the frailty strategy, which is being discussed now across Kirklees, and how that will help to deliver some of that care at or closer to home. That includes developments around of end-of-life care, about intermediate care and reablement. We'll bring back the discussion around domiciliary care and care home capacity going forward. So it's such a wide-ranging discussion. We didn't want it to focus on a specific contract around care closer to home, but thinking about how as an integrated system, working with primary care networks, we can start to deliver that more place-based around the needs of the place population of 30 to 50,000 and also individual needs of people living in those places.
Could I invite panel members to make any comments on this item, care closer to home? Peter?
We had a discussion, Helen, before you were here about the whole business of coordinating care closer to home, and who is the person who should be the lead worker. Really, just thinking in terms of anybody who's a patient in hospital has a lead consultant, and probably has a named nurse to look after them. There seems to be no such concept, and I know probably this is easier said than done, but when you've got lots of very caring individuals going into the house but not talking to one another, not even using the same set of notes, the domiciliary carers keep it separate. Things we only get this anecdotally. And anecdotal evidence can be atypical, but it does sound as though in parts of Kirklees, care close to home isn't working.
I think there's an acknowledgement it's not as we would want it to be, especially for our own loved ones and family members. And I think if we can have an open, frank discussion about what's happening now, what are we aspiring to, what the gap is, and then how we're planning to take that forward together around the table with key people that are involved with those developments, that would help. Absolutely agree. I mean, mental health, another, care coordination, care programme approach is another item where people have a coordinated named individual to help navigate their care. There are a number of people involved that are care navigators, care managers, case managers. We had a discussion about it last week at the Integrated Provider Board, but we need a format and an approach for Kirklees and about who will intervene and take that coordinating role, and at what level of complexity of a person's needs will that person step in to do that, because often it falls to the carer or to a family member to do that role.
Nell?
Yeah, I mean, I think the workshop is a really good idea. What I would like to leave with at the end of it is a very clear notion of what our regions are, what the geographical boundaries are, and who is going to be responsible for what. Thank you.
Fazila?
Workshop and having a map of some sort to be able to find out what services where and everything like that. So that'd be good. Thank you.
It has to be contiguous as well, so they've got to be touching, but there is a bit of overlap on some of the boundaries of the PCNs, but we can share all that.
I know an awful lot of people live between the boundaries.
Oh, right. We can share what we've submitted, and we can talk people through it and look for opportunities how we can do some of that. And
that is something that we can discuss more in the workshop, and allow the officers to sort of develop that for the next meeting. Yeah, the integration and health and adult social care. It's fine.
so at an operational level on the ground, obviously the council are working closer with Locala, looking at staffing. Intermediate care enablement is a good example of that, whereby we're looking at how the teams are operating together, redefining pathways, hopefully making the experience better for patient service users, and we can describe that in the workshop. Then on the commissioning side of integration, we are looking across the CCGs and council adult social care to look at how we can bring teams together to commission services more effectively, and where it makes sense to do it once. So, for example, the carers lead in the council is now the carers lead for the whole of Kirklees, for the CCGs and the council. And there's other examples where we're working together on care home support and quality as well, which we can update you on as that work progresses.
Thank you. Panel members may want to consider the Health Watch comments in the right-hand column. Health Watch are not present today, but if you want to take those into consideration or have any thoughts on that, we can include those. Fazila, did you want to come in?
No, I'm assuming that they will be attending the workshop, and we'll be able to, as long as they have the information there, that'll be fine. I just don't want to see the questionnaires, the standard questionnaires, and this is just not standard. We need to kind of have a bit of more controlled understanding of what's going on in there.
Okay. If we're okay with that, can we move on to item number 4, the integrated wellness model?
Sorry.
Take some comments on that. Sorry.
Sorry. Just going back onto number 3. Is that okay? With community pluses, I'll be really, really interested, and I'll say, you've heard me say enough times, and you're probably sick inside of me, but I'd like to know about the outcomes a year on. Where are we? What are we doing? And how it's affected the impact of the changes that we've made with Community Plus on ground level, and how it's affecting people's lives. Thank you.
Just echoing on from Fazile, when we have the workshop, if we could have some practical outcomes, you know, some positive stories of how your work has developed and what the impact has been, because, you know, like, you know, she's mentioned time and time again, we seem to be questioning what Community Plus is about because we don't really see any real impact of that service.
I think we've got some really good stories that can be told from Community Plus. I like data as much as the next woman, probably more than the next woman, to be fair. But actually, the stories are really powerful. And just thinking, you know, the Jeremy story is a really, really good way of putting across in a few minutes, really simply what Community Plus is about. So absolutely, I'd really welcome a bit of storytelling in that space.
Sorry, I like data. I don't want it restricted to data. I want it to understand what it would be.
Absolutely.
So yeah, rather, you know, the story would be quite good to know, but I want to know if it's not Kirklees themselves, but Kirklees how it's impacting.
Yeah.
Sorry.
I think we're agreeing with each other. Yeah. Not the numbers, the people and what it means to them.
Mm-hmm. Now, did you want to?
Whose job will it be to tell the bad story?
I think we can also give examples where we've had feedback from patients through Health Watch and directly to the CCG where things haven't gone as well as we would have wanted them to, and how we've taken that learning and hopefully applied it to improve the outcomes for people going forward. Can I just check? We are looking at adults in this workshop, and we may at some time want to consider what Thriving Kirklees is doing across the integrated provision for children's services. It's just a thought. Yeah, yeah.
Well, I suppose it's probably a different board that would look at the
yeah,
children.
it would be. It's just thinking of the transition bit is what I was thinking.
We would just be focusing on the adults.
Just for the clarity. Thank you.
Okay, are we okay with the integrated wellness model? No, do we want to discuss more on that?
Similar that's already been said, we're planning a scene setting workshop, but with also opportunity to ask some of that detail, look at the interdependencies with primary care networks, Community Plus, and we've already been asked to look at data and stories to make sure that that impact is shared. And I think that we'll be able to provide quite a good picture of the journey so far in terms of both of these really new services and what they are trying to achieve, and also get some feedback would be really useful for us in terms of how we really realise the impact of that resource even further.
Is that part of the workshop that we're talking about on 1st of July, that you're including that work? Okay, that's good. Okay, can we move on to the next item, which is quality of care in Kirklees?
I think when this is planned in, we just need to ensure that the right representation is from the right organisations going forward, so that you get the benefit of people being in the room at that time to get the answers you need at that time, rather than having to bring somebody else back in at a later date. So it's just about coordinating the right people to attend for that discussion.
So on that, we receive an annual presentation from the CQC on the state of care across Kirklees.
And we have just had that, haven't we? So we'd want that to be later in the programme, presumably. Yeah.
Okay. The next item is suicide prevention.
Okay, so that's me. Members of the panel are already aware of the Suicide Prevention Action Group and play a very active part in that role. I really welcome the opportunity to bring some of the progress that we've made back to Scrutiny, so we'll work with you to bring what it is that you need. We've had some progress recently on one of the issues of frustration has been getting access to the data from the coroner and being able to have that suicide data to do our audit, because our audit informs some of our actions. We've made some progress on that, and we've also started getting real-time data from the police, so we are able to have more of a kind of post-vention approach as well, because there's really significant evidence that suggests that families need very immediate support after somebody has taken their own life. So getting that real-time data, and also some additional funding that's coming down through West Yorkshire and Harrogate for the post-vention support. So we'll be really, really pleased to bring that information back into Scrutiny.
Just to follow on from what has just been said, I've noticed quite a worrying trend earlier this year in the real-time data relating to suspected suicides, and that is a real cause for concern for all of us, of course. So I think we need to be, focusing on that. And I'm really pleased to hear that there is going to be funding for bereavement support following suicide. But I would also like to advocate the extreme distress and anxiety that is caused within a family when an attempt is made at suicide, which thankfully hasn't succeeded. But it's how do people cope with that thereafter? And whilst I always applaud funding for one purpose, I like to highlight the need for it in another area. And having had personal experience of that within my own family, I can't stress enough how important it is, because other family members can become very unwell on the back of it otherwise.
Absolutely, that's a really valid point, really, really well made, and that voice is heard very clearly through the Suicide Prevention Action Group as well, but thank you for making it here as well.
Thank you.
And maybe include the results of the survey that Health Watch have undertaken. David, did you want to come in?
No, sorry.
All right, sorry. That's fine. Okay. We'll move on to the next item on mental health rehab and recovery services transformation project.
My understanding is I'm not the lead on mental health. That's still going through a development process, so an update could be brought into Scrutiny when there's more to report. Perhaps I'll go back and with the lead and identify a timescale for that, and then go back to Richard if that's okay.
That's absolutely fine. Item number 8, Kirklees Safeguarding Adults Board annual report, and that is something to be received and considered as part of their annual report. The Mid Yorkshire Hospital NHS Trust and ambulatory care is the next item on number 9.
I know you were going to visit Pinderfield. You've been, and is there some actions out of that which will then tie into this item on the agenda, which we probably need to pick up outside to say how we take it forward?
I think, Helen, we were very reassured. Am I right? We're very reassured. I was saying to my colleagues coming back, I'd always considered, and I've never wanted a tattoo, but I was going to have, when I heard about the hospital reconfiguration in Huddersfield, I was going to have "Please Take Me to Leeds" tattooed across my forehead.
I wanted to go the other way around.
I've now changed my mind. It's "Please Take Me to Pinderfields," because once patient, but it's the problem of getting people from home in Dewsbury or from Dewsbury Hospital to the actual. Yeah. I mean, I was very, very impressed with and they're doing some very innovative rostering. Consultants are doing 12 on, and I don't know how many off. Yeah. So plenty of time for the private work.
Absolutely, I'd agree with that. It was a real eye-opener. Some of the services that they are delivering are very accessible, but it's a case of getting in there to access them. And once you're in there, the systems and the structures are amazing. But again, we discussed travel and some of the perceptions of downgrading Dewsbury. And again, you know, we were sort of reassured that we'll get a visit to Dewsbury, and I think to some extent it might be myths and stereotypes about the services that are being offered at Dewsbury. But, you know, we'll wait for that visit to come along. Nell, would you like to come in?
Yeah, I mean, it's a lovely hospital, and I very much enjoyed going around it. And of course, what we don't address when we do that, and it's a bit like the whole business of looking at the NHS, is that we don't know who's got access to it and who hasn't had access to it. My brother once got shown round a private school, and he said to me afterwards, "You should see the facilities they've got for special needs in there." You know, and you can look at any wonderful organisation, but if you don't know who gets in and who doesn't get in, you're not looking at the whole picture.
Okay. One of the other things that we did talk about was the ambulatory care, didn't we? That it was like temporarily moved to Pinderfields, but it seems due to staffing issues, we're not going to be getting that back in the sort of foreseeable future. So that was a little disappointing. But other than that, it was a very good visit.
Just to clarify, what we'll be doing, Helen, is visiting Dewsbury. I think once we visit Dewsbury, I think then we will take stock of everything that the panel have seen, and then in conjunction with our colleagues from Wakefield Scrutiny, I think we'll decide on the approach that we take in terms of how we'll take this forward. So I think the Dewsbury is the next step, and then we'll take stock, and then we'll come back to you once the panel have agreed their approach.
David, would you like to come in?
With the temporary closure of the ambulatory care, do all the patients go to Pinderfields, or do some go to Leeds or Huddersfield? Is it a case that everything is then transferred over to Pinderfields during that temporary closure?
So my understanding is that will depend on the needs of the patient. So once they arrive at Dewsbury, they will look for the best pathway option for that patient. Some of the services are being provided at Dewsbury on different pathways, like the frailty pathway, and access to the frailty unit is at Dewsbury. They've also developed other fast-track pathways at Dewsbury and hot clinics with consultants either the same day or the following day, which I know you'll explore when you go to Dewsbury. Because we need to get the narrative right away from the downgrading, because actually it's a very thriving hospital, and we did a recent stock take as a CCG with council colleagues and the trust to find that actually there are more services offered at and operating at Dewsbury now than there were under the Meeting the Challenge consultation process, which I think is really positive for the residents of North Kirklees. But yeah, where you end up when you get to Dewsbury will depend on the needs of the patient. So it'll either be, if you go by ambulance, when you're in the ambulance have protocols to make a decision about whether to take you to Leeds, Pinderfields or Dewsbury, depending on your needs, then they pick you up. When you get to Dewsbury, whether you go by car, bus, walk-in or ambulance, and you're assessed, then they will then direct you to the place that needs to meet your needs, which often for some of the ambulatory pathways it will then be a transfer to Pinderfields, usually by ambulance, is my understanding.
Thank you.
One of the issues that I've come across on a number of occasions through West Yorkshire Ambulance Service is that they've been told once they pick up a patient to take them directly to Pinderfields. And again, is that because you... But what...
My understanding is the protocols were developed across Mid-Yorkshire colleagues and Yorkshire Ambulance Service, so that when the identified needs of the patients, they will, under a protocol, take them to the right place. So when they've picked them up, examined them, they will then take them to the best place to meet their needs, which is why they go direct to Pinderfields or to Leeds.
Okay, but that's nothing to do with downgrading services at Dewsbury then?
No, it's about clinical need under Meeting the Challenge. Because the expertise and knowledge is at Pinderfields 24/7, and it's not at Dewsbury 24/7. So, and time of day and need of patient, you will go directly to Pinderfield, or Leeds, as you'd said before.
Okay, thank you for that. Any more comments on number 8? Okay, and number 9, sorry. So number 10, the fetal alcohol spectrum disorder and fetal alcohol syndrome. Any comments on that? No.
Sorry, I will learn to press the button. No comments, and happy to bring the report back as necessary.
Did you want to come in, Peter?
I just wondered if we'd run that one. Into the ground last time.
Yes, do you want to come in?
Okay, yeah. Some of the recommendations that the panel made, we need to obviously follow up. In particular, if you remember, there was a big emphasis on having a network, a regional network that actually describes the protocols for diagnosis, for example, and the support that will be offered. So I think it's still very much live, and I think it'd be probably important for the panel at the very least to follow up to make sure the recommendations that they did make have been followed up, and obviously you can see what the outcomes of those recommendations are.
Well, I agree, but surely that can just be done in a written report.
Yeah. Well, as long as we get the feedback and it's still on our radar.
The work that was described that was going to happen at a West Yorkshire level is happening, so we can absolutely... I'm always delighted to see you all, but equally very pleased to send a written report.
Thank you. Number 11, transforming outpatient care at Calderdale and Huddersfield NHS. Is there any comments on that? Or the Foundation Trust? Okay. Sorry, Nell, do you want to come in?
I'm not sure whether this is the place to insert it, but somewhere I would like a record of what is available in Calderdale and Huddersfield now, and what is available at the end of the year in terms of services, because to me it feels like watching a draining bath.
We can provide that. I will contact colleagues and a written brief.
Okay. Yeah, I think we just need to be slightly careful. We've obviously got the joint scrutiny committee. Obviously, we've got the Kirklees joint scrutiny committee who are continuing to review the reconfiguration proposals. So, on the back of that, I guess that we could well get that information. So, yes, that's something that we could probably get through then.
Yeah, do you want to come in, Priscilla?
I think when we last had it, we spoke about going to see, having another visit to see some stuff about how clinicians use their technology to better help the patients. And we just wanted to find out where we are with possibly getting a visit done, or have we had any more communication? It was more the ECG machines and things like that.
Yeah, I have contacted the Trust, and they are more than welcome to support a visit to them. So it's just a case we just need to arrange a date to do that.
Okay, then the next section is lead member briefing issues. If we go through the issues individually, and then we can make comments or say where we are on that. So the wheelchair services.
So we're just continuing and about to end the procurement process for the new wheelchair contract. That will go to governing bodies for North Kirklees and Greater Huddersfield in July. Then we have something called a standstill process while the winning bid is then announced after that 10-day standstill process, so that will then be announced. But we'll take into consideration the comments. Service users were involved in the evaluation process and kept very rigorous comments on each of the potential bidders.
Okay, Priscilla, did you want to come in on that?
Last time we had a very long discussion about waiting times and repairs and everything, and just wanted to hopefully you can reassure me to find, say that you've got some more detailed information information and the fact that we're up with our waiting times and contracts.
So both CCG's Clinical Commission Groups monitor it on a monthly basis through their Finance Performance and Contract Committee. Additional finance was put into the existing wheelchair service to bring down both waiting times, the waiting list, and also the provision of specialist equipment. So when we get a handover to a provider, if it is a new provider, then there should be no waiting list or waiting times that are beyond what we would expect as part of the contract going forward.
In the approach section, we have that findings are to be reported back in a written report. Do we have a date for when that will happen?
We can give an update now on the existing contract if you would, where we've got to with the investment and how it's reduced the waiting times. And then when we know what the outcome of the tender process is, we can inform you of that as well. So do you want to do it together probably in August? So we can do a written report. Oh, sorry, September?
Yeah, we don't have a meeting in August, so we could look at the September meeting.
As a written report?
Yeah.
Sorry, I'm skipping back. We didn't have the conversation about when you want the written report for the fetal alcohol work. Have you got a date in mind?
I think what we can do is we need to work through the work schedule. So I think once we've identified all the items that we will be taking forward this year, we'll be in contact and start working through individually with you items that are specific to your area and the timescale.
We didn't consider it until early this year, did we? It was like February or March or something. So, you know, we would expect people to have it, 8 months anyway. You know,
If we can move on to the second item, which is interim changes to acute inpatient elderly medicine, cardiology and respiratory services provision. So the arrangements are to be made to visit the CHFT to see changes that have taken place, subject to panel members agreeing. Do we want to put a date in that?
Yeah, can I suggest we do that not in a, that date isn't one of our meeting dates, it's another date, if you see what I mean.
I think what we were planning to try and do is put the outpatient stuff as well as, so it's possible we might be able to combine the two. So I'll liaise with CHFT and obviously the members to get a date that suits everyone.
The next item is Kirklees Health and Wellbeing Plan to include work emerging from the West Yorkshire and Harrogate Healthcare Partnership. So that is an item that we monitor and implement. And then we've got the monitoring items, review of mental health assessment. And that is lead member. We don't need to go through this, do we? Okay.
Can I say, I think a review of the ambulance service would be really useful, because I've heard that they now use both the fire service and the police service for defibrillators when they suspect they've got a heart attack going on that they can't get to. And it would be good to have a look at all of that.
We could include that in one of the future meetings when we go through the dates. Okay. The second item is the primary care networks.
So we've...
Again, that's a developing piece of work, isn't it? And we could include that at one of the future meetings too.
I think we can talk about the workshop.
To start the discussion.
That'll be good if we can start it at the workshop and then see how that develops, Or maybe if we could schedule it for maybe 6 months' time from the first session and see how we progress with that. And clearly it's going to be a partnership initiative as well. Number 3, West Yorkshire and Harrogate Local Maternity Network. That is just to consider the maternity services and as part of that plan. Is there any comments on that?
Yeah. Oh, sorry. Alarm wrestle, go on.
I'm actually meeting Karen Poole after this meeting, who is the lead across West Yorkshire and Harrogate for the local maternity system. I think it would be useful to have an update here and about what we need to develop locally and how we're going to take that forward, and especially around development of maternity hubs, which we're hoping there'll be 1 or 2 across Kirklees. So if you'd like to suggest a timescale, I can speak to Karen about that.
Yeah, I'd be particularly interested in the community hubs. Again, when we go through the timeline of the meetings, we can include that and let you know. Then number 4, the vaccine.
Happy to bring that here. It's presumably just in the form of a written report and an update on where we are and plans for the future. Do you just want to do, at the risk of giving us more work to do you just want to do HPV, or do you want to do baconyms in the round? Yeah, okay.
Sorry, and another one, Emily, we saw from the examiner that there's a lot of resistant gonococcal infections in Huddersfield, and if we could have an update on sexually transmitted infections in general, a written one, just really to see how we're faring.
Yeah, well, we could just do UA diseases generally, how things are going. There are some interesting things on the rise, which are something we got. That was a really unfortunate sentence, wasn't it? It was. Yeah, absolutely. No, I heard the words as they came out of my mouth and regretted them as I said them. But you know what I mean. Yes, we'll bring you a thing in the round.
Sorry, I heard about this new virus a few years, at least about 2 or 3 years ago actually, but it was in Leeds. So obviously it's come, our way now. So it's obviously on the increase. It would be interesting to know what we can do about it. It's really worrying.
Absolutely. One of my proudest moments is my son is now 16, but when he was having his PSHE lessons at school and they were talking about the general mechanics of how this stuff works, he introduced the concept of antibiotic-resistant gonorrhea to a class of 11-year-olds. Very proud moment.
Zilla, did you want to come in there? Did you?
Just to find out, obviously, with the changes in the way the administration of the vaccinations that happens from GPs as well as pharmaceutical doctors now, so what is the uptake like geographically, north and south divide, and how many more possible places that we have got that available to do? Is that all right? Thank you.
And the last item on that is the update on winter planning. Yeah. So we have an update on planning. We usually do get updates on at Scrutiny on that. So if we can include it in the September panel, maybe.
Can I suggest later, because there's usually, we have to do submissions to NHS England from across the system with the acute trusts and integrated providers. Can we check the timetable of that submission? Because as that's been worked up, it would probably be the right time to bring it to scrutiny. I think it'll be later than September. It may be October. But I can check out.
Okay, so will you get in touch with us or get in touch with Richard and then... Okay.
Just on the subject of the update on winter planning, I'm thinking it would be useful to have
an indication of lessons learned from last time round, particularly looking at flu vaccinations with a focus on older people and yes, vulnerable people, shall we say, that's a better term of phrase, just to see what more can be done to increase the take-up, please. Just to offer some reassurance around the flu planning, I know that it's happening now. We are planning for the vaccination programme, and to coin a Game of Thrones, winter is coming, isn't it? So we need to get ready for it, and we've started that planning. We haven't had summer, but we've started the planning for flu vax already.
Thank you for that. Myself and Richard will work through, the future agenda items, and we'll be in touch with you there. Thank you for attending. In terms of the next item, dates of future meetings.
If we can add Locala and the changes with Locala onto our work plan, obviously with all their structural changes and their changes to procurement. Well, that, see whether it could be more in detail just based around a lot of the services Locala do rather than the whole community angle, the community plus angle.
Well, I think I've also asked if we could have that on the agenda earlier because of the issues that I'm coming across with the new restrictions on the 17 surgical procedures and all the appeals that are being refused. I want to know the system doesn't seem to be working, so that's something else that I'd like to look at. Thank you.
I think it's a session on its own. I think we can do it in the workshop, but I think we could equally have a meeting about it, don't we?
Yeah. Do you want a separate meeting away from the panel meeting?
Have it in the workshop, but also set aside one of these for a look at it.
I'm just trying to clarify. Are you wanting it as part of the panel meeting, or are you wanting a separate workshop? A separate meeting away from...
No. I'd like it to be one of those meetings, if possible. We haven't got too much to do.
Yeah. Okay. Okay. We can work on that and come back with a proposal on future items on the dates that we're proposing. So, is everybody okay with the dates that we have proposed? Would you like to come in?
Yes, please. I would just like to request that when we're looking at the work of Locala, I have some concerns to express relating to the podiatry service that they deliver, and I would like that to be included as well, please.
Yeah. What we can do is when we go through the work program, we've identified now, effectively most of what's on the work program is obviously going to go forward. We've identified some of the specific issues you've got. So what we can do is we can meet and have briefings in advance of some of the meetings, so we can meet, for example, Karen Jackson, Chief Executive of Locala, and then if you can highlight, so what we'll do is I'll invite people to comment in terms of some of the issues they particularly want to raise with Locala. We can discuss that with them in preparation for them to come to a meeting to obviously address those concerns and issues. Is that okay?
We come to the end of our meeting now. Thank you everybody for your contribution. And in terms of the next meeting, which will be held on the 16th of July, that will be a workshop style with some of the partners that we are working with. So that's the close of the meeting now. Thank you.